I'm going to start off with a case to kind of get your thinking started. This is a 64-year-old woman, prior history of stage 2B node-positive breast cancer, treated with breast-conserving therapy and adjuvant chemotherapy 7 years ago, did well with therapy. Her only other past medical history is obesity. This was a little out of order, maybe backwards, but I have no disclosures. Let's try that. Okay. So she presents to your office with increasing dyspnea on exertion and fatigue for about 2 months, and she's very perplexed because she leads a healthy lifestyle. She walks 2 to 3 miles a day. She's doing everything right. Physical exam, she's got normal vitals. She looks pretty comfortable. Everything's looking pretty good until you listen to her heart and lungs, and she's got new bibasilar crackles and a new S3 gallop. So you start looking into things. Her labs are normal. Her ECG is pretty unremarkable, but she's got pulmonary vascular congestion, and her echocardiogram is pretty striking. She's in heart failure. So why does this woman have heart failure? She has no structural heart disease. She doesn't have a history of cardiovascular disease or any really significant risk factors. She barely drinks alcohol. She's never smoked. And she doesn't have a family history. So why does this woman have heart failure? Well, you go back and you look through her chart, and her average, I'm sorry, I'm ignoring people behind me. Her average blood pressure during chemotherapy was actually elevated. Baseline BMI during treatment was 37. She was never treated for her hypertension. Well, you hope that it was discussed, and she's at least taken action herself because her blood pressure is now normal and her BMI is near normal. Lifestyle modifications were never really addressed in her medical record. You look back further, and you see that she had anthracycline-based chemotherapy, but her dose never exceeded the maximum cumulative lifetime limit. But there's no other etiology you can identify. So you have to come to the conclusion at this point that she has a late onset chronic progressive cardiomyopathy due to her chemotherapy. When you think about it and you look through the literature, you realize she was actually at higher risk of this developing in the first place because of her hypertension and her obesity. This graph shows, based on age, these are older data, the cumulative dose of doxorubicin, one of the anthracyclines, 450 milligrams per meter squared, cumulative lifetime dose. And I don't think do I have a pointer on this? Yeah. Ah, there it is. But if we take a look at this slide, we have evidence that's been accumulating over at least the last decade that shows a split point down closer to 240 milligrams per meter squared. We are starting to see cardiotoxicity at much lower doses than we actually thought was true. And this looks at epirubicin, another anthracycline, and you can see out at least 5 years after completion of treatment, if not longer, we have some pretty significant rates of heart failure possible. Older data, but still significant. This is not a solved problem. This is way too complex to get into in the scope of this very short talk, but suffice it to say that anthracyclines affect cardiomyocytes in profound ways at the cellular and molecular levels, and it's multifactorial. Some of these we understand, some of these pathways are just now being worked out, and there will undoubtedly be other pathways that we have yet to discover. So what are the risk factors we have to think about for anthracycline-mediated cardiotoxicity? Well, we've known for a long time cumulative dose, that's led to upper limits, prior thoracic radiation, particularly under age 30, and we're starting to understand better patient-related factors, but these are far from completely defined. For this particular patient, obesity, hypertension, and the fact that she's female were risk factors for anthracycline-based cardiotoxicity occurring. I did not mean to highlight this. However, this is a very interesting part of the field, non-modifiable risk factors, at least in the current era. We're starting to get more and more information that still requires more elucidation about genetic susceptibility to anthracycline and actually targeted therapy-based cardiomyopathies. In terms of clinical manifestations, I'm not going to go through this in detail, but we have acute and subacute and chronic, and this woman clearly has a more chronic cardiac event. So back to the patient quickly. She was treated for her heart failure. She did well. She's already started working on these lifestyle modifications. You're going to fine-tune them a little bit better. So if we think about breast cancer and heart disease, we're starting to really understand that there's a convergence between these two entities. I think most, if not all, of the people in this room understand that breast cancer is the most common cancer in women. It's the leading cause of cancer-related deaths globally, whereas cardiac disease remains the #1 cause of death in women and accounts for a highly significant number of global deaths, exceeding combined deaths from a multitude of disease states. And I know you guys can't see very well, I'm sorry. So we have a problem that is in part due to all of the gains that have been made, survival gains from earlier detection, from improved therapy, but also from our treatment modalities themselves. And so these are really important questions we need to be asking ourselves when we're treating these patients. And if we look at this a different way, this is all comers with breast cancer, a little bit older data, a survival. Heart failure remains dismal. So most women are going to survive their breast cancer, and a proportion of them are going to live long enough to go on to develop heart disease that's significant and related to their breast cancer treatment. This is just looking at it a little bit differently. And so we really have to think about each patient as an individual. What are her own risk factors? What are the benefits of treatment? What are the risks of modifying her treatment to try to deal with potential risks? And how can we start thinking about monitoring tools, developing those better, biomarkers and imaging, which I'll just touch on a tiny bit, and starting to employ cardioprotective medications and other preventive strategies. This is far from standardized and far from widely accepted right now. So this has really led to the emerging and really fairly well-established multidisciplinary field of cardio-oncology, which is really a convergence of the care of medical and radiation oncologists, cardiovascular medicine specialists, and internal medicine and family medicine specialists. And it's really hard for me to underestimate the importance of this group of providers to these patients. This is really important because these are the people who are going to be detecting these disease states after they're no longer being seen by the oncologists. This is a map. It's a couple of years old. It just shows the cardio-oncology clinics across the US. So this is really a building field. So I'm just going to try to go through this really fast because I know we're short on time. This is kind of the current clinical approach. It's moving out of this, but it's really damage control. Clinical heart failure, clinical disease states, and trying to mop up the mess. Trying to move more into identifying myocyte dysfunction before the patient has actually developed clinical disease. And so this is being looked at through multiple modalities, and I'm going to skip through a little bit of this here. We're looking at biomarkers. Some look very promising. Others have not been as promising as we had hoped. There will be others that emerge. Newer cardiac imaging and functional assessment, and I'm not going to go into detail here because we're very short on time, and I want to be respectful of everybody else's time. And really thinking about preemptive treatment of stage B heart failure, which by definition, AHA-ACC guidelines, all of these patients have by virtue of the fact that they're being treated with these agents in the first place. This is really where we need to be. We need to start with a patient with a normal heart, and we need to try to keep it there in whatever way we can without compromising their cancer treatment. I'm going to kind of skip through this here. So really moving from treatment of heart failure in this particular instance to damage control, which we're kind of currently doing but moving out of, into risk reduction, the emerging standard. Primary prevention is the ultimate goal. So a lot more to talk about, but I'm going to stop there. What's that? Did I really?